All right, it's about 3 minutes after noon, so I'm going to go ahead and get started, and attendees will come as they can, and we'll go ahead and get started here. So my name is Molly Peterson. I am the Director of Programs at the Center for Youth Wellness, and I am going to walk you through some of the ACEs science today, and then I'm going to hand it over to my colleague, Carissa Luckett, who is going to talk a little bit more about screening and specialty clinical areas and get into screening tools and key considerations. We're excited to have you all here today. As I mentioned in the chat, if you would like to, if you feel compelled, please feel free to put your name and your organization in the chat so we get a sense of who's here. It's always nice to know who's, we can't see your faces, and so it's always nice to see, just to hear who's in the audience and who's really interested in this subject. This presentation is being recorded, and we will send out the presentation itself, the slides, and the recording probably next week to everyone who signed up. So if you had a colleague who signed up but wasn't able to make it today, they will get the recording and the slides. This is just a bookmark. This is the last of our presentation series that we're doing with in conjunction with ACEs Aware. And we're really, it's been a wonderful relationship with ACEs Aware doing these trainings. We hope if you've attended a few that you've enjoyed them and they've been helpful for you. So with that, I'm going to go on to the next slide. Thanks. So a little background on the Center for Youth Wellness. We were founded in 2012 by our first Surgeon General, Dr. Nadine Burke-Harris. CYW led the conversation on addressing ACEs and toxic stress through screening interventions and building resilience. We seek to build health through multifaceted programming in one of San Francisco's most disadvantaged neighborhoods, the Bayview Hunters Point, in collaboration with the Bayview Child Health Center Medical Clinic. So our model is a little unique. So if a patient comes into the Bayview Child Health Center, there is the chance to have a clinician from CYW embedded in that appointment to speak to that patient about ACEs and trauma and toxic stress, and then they can be referred over to CYW itself and actually get help from our clinicians there as well. So it's a pretty unique model, like I said, but really great integrated care. And through a lot of the lessons that we've learned in our relationship with BCHC, the Bayview Child Health Center, and through many, many different pilot sites that we've done across the country, we had 2 cohorts of pilot sites that we walked through starting screening in their clinic, everything from a small rural clinic to a large medical health center. We have come up with what we call the ecosystem model. So it understands, Chris, you can go to the next slide. It understands that the patient is really in the center, the family is really in the center, and that there are so many different parts of that family's life and places that they interact with, that screening is really only part of that relationship and that family's life, and that screening can really be helpful, but there needs to be lots of different resources within the family and then out within that community that need to surround that family and help them. If there is a diagnosis of ACEs, or if there is a diagnosis of, a rise in toxic stress because of ACEs, or if there's other, oftentimes trauma screening can uncover other issues that the family is having. So we shouldn't be just really restricted to only being able to send referrals over to mental and behavioral health. There should be a really robust system in place for other referrals to other community services that family can access, and the building of a relationship, really between the medical system, the family, and the community. So the community and the medical system should be in relationship just as much as the medical system should be in relationship with the family. And one of the other things that we have done in the past is really worked on policy as well. So that's really a high level, making sure that there are systems in place for these families to get the help that they need. Next slide. So to get really specific into ACEs, so what are ACEs? You have probably heard all of these before. These, we mention them because they are the ones that have been studied the most since the Felitti and Anda study in 1998. So what we call the 10 core ACEs are put into 3 categories: abuse, physical, emotional, and sexual; neglect, physical and emotional; and then household instability. And we use the definitions that were used in the Felitti and Anda study, but we know some of these have shifted slightly. So when it says mother tried violently, we know that's really just violence within the family, or divorce. We really know that that's the loss of a caregiver in any way through divorce, or if a caregiver moves out of the home, or through immigration. Lots of different things there. So those are sort of the narrow net definitions that have been expanded since then. And really, again, I want to make sure that we understand these are the sort of what we call the 10 core ACEs, and they're the first 10 questions on the PEARLS tool, which is the tool that's used for children, for screening for children, and is reimbursed through Medicaid in California if you're based in California. But we know that there are so many other things that can happen to a family, to a child, even to an adult, that can have effects on their physical body. And so we talk about sort of this pair of ACEs. This is something that was put out a number of years ago, and I know I've seen it in many different places. But so there can be sort of community environments, and then actual ACEs, and we just know that there's that's why on the PEARLS tool there are, I believe, 7 other questions that get to some of these more adverse community environments, because we know these can have effects on physical health as well. So the next 3 or 4 slides go through a lot of the physical effects of ACEs, and this is kind of the crux of what Dr. Anda and Dr. Felitti saw, as well as Dr. Burke-Harris, and lots of research afterwards, which is that ACEs can really affect a person's physical health. And we know that because if a person has 4 or more ACEs, their likelihood of death goes up. Their likelihood of death by one of the leading causes of death goes up the more ACEs that they have. So for anyone with 4 or more ACEs is more likely to die of heart disease, cancer, chronic lower respiratory disease. And then on the right, you can see the actual ratio. So this is the increase in the association of their death with when they have 4 or more ACEs. So you can see that those with 4 or more ACEs are 30 times more likely to die of suicide, and without intervention, there could be a 20-year difference in life expectancy. So this slide really talks about the dose-response relationship, but I kind of want to pause, because this is really where Dr. Burke-Harris started to think about what ACEs could be doing, because where she was seeing, what she was seeing was the physical manifestation in her office. So she tells a really interesting story in her book about how she saw a patient who had recurring asthma and they weren't getting any better. So she was using everything in her medical toolbook that wasn't helping. And then the mom told Dr. Burke-Harris, well, the asthma is exacerbated anytime the father punches a hole in the wall. And that was kind of an aha moment for her, like there could be something else going on here. And so this slide really talks about what we call a dose response. So the more ACEs a child accumulates over their lifetime, the more likelihood they are to have physical effects later, and worse physical effects later on in life. And so these are really some of the things we talk about: growth delay, cognitive delay, asthma, infection. These are things that can be worsened by ACEs. And so there are things that we have a symptoms checklist as well that I don't think we have in this presentation, but we can send it out. And so it really talks about how, if you're seeing these symptoms, there may be, and they're not going away, especially then they're not going away with normal, medical interventions, then there could be something else going on and we really need to investigate. Now, we also advocate for universal screening in childhood, because we know we don't want these things to happen later on in life. And so the earlier you screen, the more likelihood you are to catch the ACEs early and help with interventions, and then you won't see these physical effects later on in life. So that's kind of the two sides of this, seeing these physical effects. Next slide. So again, when you see some of the physical effects, worse asthma, cognitive delay, growth delay, things like that, these are the systems by which those physical effects are happening. And so ACEs, the trauma and repeated trauma without a caregiver can affect the neuroendocrine and immune systems. So these are inflamed and they are made worse by what's going on in trauma, and that's sort of the process by which you can then see these physical effects later on because of what's going on. And then we also know that ACEs can affect epigenetics, so they can actually be passed on, that the trauma itself can be passed on through genes to the next generation. So toxic stress is really the mechanism by which ACEs can affect the physical body, but we want to make sure that people know what toxic stress is. So not all stress is bad. We all go through stress all the time. We have stressful meetings, we have emails that we have to answer, we have things that we have to do, and our system gets a little elevated, but then it gets regulated and goes back to normal. Tolerable stress responses, there's a death in the family, it's a really high elevation of that stress response for a little while, but again, there's a caregiver, there's buffering resources there that can help that stress response go back to stasis. Toxic stress is if that stress is constant and there is no buffering resource, and therefore that stress response is elevated all the time, and the body just gets so exhausted from the stress all the time that things can elevate, and that's where the physical effects start to happen. Next slide. Krista, you can go to the next slide. Oh.
Sorry, Molly, I'm having
that's okay. Go ahead.
Technical
so I think
difficulty.
With that, that's okay. I think with that is it. I'm going to hand it over to Carissa.
There we go.
Right. Okay. So we did. I have 2 more slides. So we talked a little bit about the physical effects of toxic stress. We really like this graphic because it's what it talks about is really that there are so many different things that can go on a person's life that can affect whether they are negatively affected by ACEs or not. And we always say ACEs are not destiny. Just because a person has ACEs in early life doesn't mean that they're destined to go on and have physical effects of that. There is a lot of things, and we'll talk about, you just saw the slide on the 7 domains of wellness. So those are some of the buffering resources that a person can take on that will help them. But really, it has a lot to do with, it has something to do with DNA, it has something to do with the buffering resources, it has something to do with a person's mental state. So there's a lot of different ways that we can affect those ACEs. And so the more positive experiences a person has, it can really buffer the effects of toxic stress and ACEs. And so these are the what we call the 7 domains of wellness. These are activities that we know through the research have been proven to help buffer the effects of toxic stress. And so I'll go through them really quickly. Supportive relationships, we know this is the #1 way to buffer the effects of ACEs and toxic stress. And so if there is a supportive caregiver in the child's life, whether it's a parent, another member of the family, a coach, a teacher, as long as there's somebody there who can help that child through some of those traumatic experiences, we know that that can buffer the toxic stress response. The others are eating healthy, sleeping well, using movement, practicing mindfulness, supporting mental health, and spending time with nature. And really quickly, just to say, nobody has to do all of these. Even picking one of them and trying a couple of things in that particular domain of wellness can be really helpful. The more domains that a person tries, the better outcomes they may have, but it can be really overwhelming in a lot of cases to try and take all these on at once. And so we want to make sure that people understand that even taking on one is great and can be really helpful in toxic stress response. So with that, I'm going to hand it over to Carissa to talk through the ACEs screening and specialty clinical areas.
Thank you so much, Molly. And thank you to everyone for your patience with a little bit of technical difficulty. So I'm going to talk to you all today about the screening for ACEs in specialty clinical areas. I share with you first the 2 tools that are approved through the state of California through AB 340 for screening for ACEs. On the left, you'll see the ACE-Q, which is, it says child, but it is actually approved in an augmented phase for adults. And the tool on the right is the PEARLS tool, which goes over the 10 core ACEs that Molly went over in the top box, and the additional ACEs that we talk about in the pair of ACEs in the bottom section. And so you will note on these 2 tools that I have in front of you here, we refer to these as de-identified tools, and that doesn't mean that we don't put the patient's name on the top. What we refer to in that vernacular is that we aren't asking which specific adversities the client or patient may have experienced. We're just asking for the total number. And some of you may be thinking, why on earth would you do that? And that's a great question. I struggled with that when I first came to the adverse child experiences world. And we have found over the years that when we use the identified tool that asks yes or no for each of the questions, the 0 or the no response rate is very high at 99.8%. Individuals are likely to disclose whether parents or guardians are separated, but that's about it. And when we're really thinking clearly about the purpose of these tools, and that is the true goal is to screen for toxic stress, we realized that we didn't really need to know which adversities were experienced. What we really needed to know were the total number of experiences that individuals had, so that we could have a much more accurate screening for the likelihood of toxic stress. And so we went to a de-identified tool many years ago in most of our clinical settings. I did sneak the toxic stress checklist in at the last minute, so you all could see that. And so we have created this and shared it with many clinical settings. Our colleague, Dr. Rachel Gilgoth, actually did an extensive review of the literature with regard to these symptoms and has evidence-based articles to support each of the symptoms. And we have a wonderful white paper, if you will, on the symptoms and how we've come up with this list and the references to support that we can send out along with the recording, and we'll be happy to share those with you. But you can see here we have broken them down into age-specific concerns, mostly focused on pediatrics in this particular handout, and by the neuroendocrine and immune systems, as well as some potential unhealthy coping adaptations. We also recommend, as does the Surgeon General, which you can find on the ACEs Aware website, that while you're screening, you use a scoring algorithm to help determine the risk for toxic stress. And so typically in pediatrics, you'll see a scoring algorithm set up like this, with the low score being a 0. And we would certainly recommend that you still provide anticipatory guidance around ACEs and what is toxic stress. There are wonderful patient education resources available on many websites, but certainly the ACEs Aware website, that you maybe consider intermediate risk for toxic stress with a score of 1 to 3 with no health problems, as seen on this previous slide. So we call that no symptoms in our vernacular. And then a high risk for patients who have a score of 1 to 3 plus symptoms, or those individuals with 4 or more ACEs. And certainly with the high risk stratification model, we would encourage you to do a further assessment and look at what additional issues may be going on, maybe do some of the social determinants of health assessments, as well as maybe some of the additional screening tools that we will be discussing here, as well as maybe scheduling a follow-up, certainly to monitor the symptoms that may seem to be associated with the toxic stress. And so there can be some additional monitoring by a medical provider. Again, this is just another representation of those clinical symptoms. And we really like to think of these as not necessarily a new onset of asthma, but really more in the context of, as the ACE score has gone up, maybe over a short period of time, the asthma symptoms are worsening, or there are more frequent exacerbations of colds, eczema, that type of thing, or diabetes is poorly controlled. And so again, these are not symptoms, these are symptoms and not clinical diagnoses. So certainly would want you to consider the complete picture of a patient's chronic diseases in the context of adverse childhood experiences. So I'd like to transition now and talk a little bit about screening in specific specialty populations. And so when we talk about pediatric asthma, whether that's in the pulmonologist's office or the general pediatrician, or even the allergy immunology subspecialties, we can certainly see a clear correlation between the manifestations of toxic stress and the impact on that inflammatory cascade. In fact, the Center for Youth Wellness has started the National Committee on Asthma and Toxic Stress, better known to us as NCATS. And I'll be sharing a link to our first webinar that was presented several months ago, as we dive in deeper on the correlation and possible treatment implications for these two co-occurring conditions. We also know, for those of you who are familiar with the NHLBI guidelines on the treatment of asthma, that the definitions of around high risk for death and some of the ACE categories and additional adversities overlap. And so we see a direct correlation there, and that has been noted since the 97 publication of the NHLBI guidelines. So having parents with mental health, specifically depression, there's been a lot of research around that, and children with uncontrolled asthma. So it's clear that, again, there is some risk associated with ACEs and uncontrolled asthma. And we know that screening for ACEs can help particularly be beneficial for those individuals who are at higher risk related to their asthma. So we often see the use of the asthma control test in pediatric asthma, but this can be something that is integrated in a useful way in a general pediatric practice. So looking at the ACE score as well as the asthma control test, or ACT score. And this tool was actually developed back in 2002 by GlaxoSmithKline. It is correlated with PFT in several studies, which has been very interesting and helpful in pediatric offices where they may not have accessibility to pulmonary function testing. or in rural settings where pulmonary PFT, full PFT labs are not available. And we see that with a score over 15, that there generally warrants some further assessment. So a couple of different ways to use this tool may be that you use the asthma control test prior to screening for ACEs. And if there's a poor score, a score of 15 or greater, that you also screen for ACEs. You can do that vice versa, but we do not recommend that the asthma control test, the ACE-Q or the PEARLS to be evaluated more frequently than annually. There is little literature to support more frequent evaluation of that. However, you may use the PFT or the asthma control test much more frequently. And we recognize that this may have its highest value in high-risk clinical settings for asthma, like those high risk for death asthma clinics that many larger academic clinical settings have, or in larger cities. But may have a great deal of value in the pediatrician's office when you're struggling to figure out why there's poor control for asthma clinical symptoms in the patient, that you have a fairly good impression that compliance is high. So if you're wondering what else could be going on with a patient that's struggling, this may be a really good opportunity to deploy the PEARLS tool to assess for adverse childhood experiences. Here on the bottom, I have the link for the NCATS webinar, which is free. You do go through Shopify, but there is no cost for it. And there is a CME option for you to learn more about our work with regard to asthma and adverse childhood experiences. So talking about screening for ACEs in the OB setting. Again, some of the physical manifestations of toxic stress can be seen in the high-risk OB setting. So where we see drug use or poor OB follow-up, poor management, smoking, those types of things are all correlated to our maladaptive coping within toxic stress, as well as diabetes and even gestational diabetes. And in earlier in the 2000s, there was an excellent study, which I have listed for you here in 2018, and then replicated in 2021 through the and published in AJOG, is a study looking at ACEs and postpartum depression. And of the 225 people enrolled in the study, there was a clear link between women who have postpartum depression and those who have a higher ACE score. And so the study found that it was clinically and statistically significant that the respondents had a higher likelihood of ACEs in the general population than the general population who had postpartum depression. And so there is ample evidence that there is a correlation and crossover between these two things. And so an excellent adjunctive screening tool to use in OB certainly is the Edinburgh, which is the gold standard for postpartum depression. And with this tool, any score greater than 10 is considered at risk, and certainly any score greater than 13, or if the question number 10, which it has to do with thoughts of harming themselves, if there's any score greater than a 0 there, most organizations will do a further assessment. Again, the screening intervals most often seen with the Edinburgh are pre-delivery. Many organizations are doing this shortly after delivery, and then at the OB follow-up. The important thing to note here is about 40% of women do not attend their OB follow-up appointments. So it can be very useful in those earlier settings to look at the postpartum depression screening score and see if it's going up. And certainly if from pre-delivery to delivery, it has gone up, it may be useful to go ahead and look at the ACE-Q score as an additional screen. Again, we do see those clinical manifestations of toxic stress are correlated in the high-risk OB categories, such as smoking, drug use, and obesity. And again, this tool or the use of both of these tools together may have value in a high-risk OB clinical setting or hold the highest value there. If you're working in an OB office, it certainly might be helpful to screen for adverse childhood experiences at some point along the continuum of care prior to delivery and help identify those moms as being at high risk for postpartum depression, according to some of the literature, and then maybe doing more proactive follow-up to make sure they come in for their postpartum visit, as well as making sure if they don't come in that you reach out to them and do some additional screening. When we look at screening in the adult medicine population, I just shared here the co-occurring ACE-associated health conditions that certainly we see with regard to scores higher than at 4 or more within the original Kaiser study. So these are all clearly linked to physical manifestations of toxic stress. And so if you're in adult medicine treating patients with many of these or any of these chronic conditions, it very well may be helpful for you to look at screening for ACEs and the presence of ACEs, and helping to really get patients and individuals to understand how their adversities may be impacting their chronic disease and their chronic disease course. This can also often provide additional motivation, if you will, if you're thinking about Prochaska's readiness to change model for individuals to address some of their lifestyle or domains of wellness opportunities with regard to their chronic disease like diabetes. And so that can be very helpful in aiding in that discussion. And I know many, almost all federally qualified health centers and other adult medical providers are already using the PHQ-9 and maybe also be using the BEC or the GAD. But this in conjunction with an ACE-Q can also be very helpful. So for patients that you have that maybe don't have a chronic disease that we just looked at on the list before, but do have a higher PHQ-9 score, the ACE-Q could be very helpful in looking at maybe some additional reasons for the depression that you may want to address within your practice. And so certainly with the PHQ-9, we see scores over 10 generally being at risk, and then severity broken up by stratification as well, as you can see there. And of course, the PHQ-9 has a very, very good scores, or it has been validated for sensitivity and specificity with regard to major depression in numerous studies throughout the years. Again, those clinical manifestations of toxic stress. So, you wonder which came first, the chicken or the egg. And we know in depression, chances of smoking or likelihood of smoking and obesity are very high for those who have depression. And we see that the same with regard to higher ACE-Q scores in adults. So again, these assessment tools can be very helpful in trying to get to the bottom of what's going on with your patient families, and also provide them even just using the assessment tools to engage in conversations about how chronic diseases impact their health, as well as maybe some of the high risk behaviors throughout the years. And these can be very useful, again, when incorporated into patient education. The last tool I'd like to go over with you for use within additional populations is one that has been getting a lot of discussion and press in the medical settings, and that is screening for human trafficking. And we see this as being very important because we know it's particularly troubling how much trafficking is on the rise within the United States. We have often noted that the most common places where individuals who are being trafficked are discovered or can be assessed and helped are in a clinical or a medical setting. And so many states have already mandated human trafficking screening in the OB and emergency rooms, probably more commonly in the OB setting, but under certain circumstances, certainly in the ER. And again, we see this overlap if you look at a Venn diagram of the physical manifestations of toxic stress and sort of symptoms of, or often co-occurring conditions in trafficked adults. We see a high propensity of drug use, a lot of teen maternity, frequent STDs, that type of thing. And so that this can certainly be important too in the overlap between the treatment for toxic stress and trauma, as well as treatment for human trafficking, and that the key consideration there that it be very much trauma informed. So if you look at some of the questions on the trafficking tool, and many of these have already been built into common EHRs like Epic. You'll see individuals who may not have adequate transportation or may not have any ID or passport available to them as they've been taken away from them. And trafficking can certainly include work trafficking, sex trafficking, and many other forms. You can often see tattoos or branding on the bottom of the foot or on the wrist area. There are two well-known trafficking organizations that are monitored through the FBI and Homeland Security that have known tattoo markings, one being on the foot and the other being on the wrist. And so just having an opportunity to screen individuals again for ACEs. If there's a high rate of ACEs and you're encountering this mom or individual in the OB setting, you may want to also look at a trafficking questionnaire or vice versa. If you're an individual who has been referred, a client who has been previously engaged in trafficking, the PEARLS and ACEQ tool are extremely valuable in helping to understand their background and what trauma they may have experienced prior to engaging or being recruited into this very difficult and challenging lifestyle. And so with that, I would like to stop and take questions from the audience, any of the participants, or comments that you may have.
Thanks, Carissa. There's nothing so far in the chat. If people have questions, feel free to raise your hand or put them in the chat. We have also had, we've had some really great, we did this presentation for another organization, and we were able to have a really great discussion on sort of how people have been screening. So if you have any stories you'd like to. All right, so I got one from Trisha. The slides and the forms will be available hopefully next week. We just have to download the recording and do some editing. So it takes a little while, but we'll get them out to you as soon as we can. And then Jeffrey, I'm gonna allow you to talk. It sounds like you'd like to make some comments.
Yes, a very good presentation. I'd like to make a few comments. I'm a family doctor and I see it from the adult perspective. Number one, with regard to children, the literature clearly shows that children in juvenile hall or other facilities like group homes have a much higher incidence of ACEs than the ambient population. But that housed population has not been well studied in detail. So anybody that deals with foster children or children in group homes or juvenile hall populations needs to be extra sensitive. Number two, speaking from the adult point of view, it's important to make some observations, which I want to share with everybody. One is that the CDC uses a statistic, which is an epidemiological statistic called population attributable risk. And in regards to that, for instance, with regard to DSM-defined depression, the CDC has said that the population attributable risk, this does not mean cause, is 44%. And with regard to ordinary adult chronic diseases, the population attributable risk for coronary artery disease is 13%. Now, that's not particularly impressive until you understand that the population attributable risk of diabetes for coronary artery disease is 13%. And needless to say, all of adult medicine pays a lot of attention to diabetes. But you'll all agree with me that adult medicine does not pay much attention to child abuse trauma as a contributor to coronary artery disease.
Yeah.
The next thing I'd like to say is that it's very well known and studied. I can tell you the smoking and alcohol habits of people who score high on ACEs, but there are no studies that I know of smokers or alcoholics as the population, looking at the number of them that have ACEs going the other way. Also, there are no studies, and I don't think anybody uses trauma-informed care to do smoking cessation treatment. And that tells you how much behind adult medicine is in applying the knowledge that you've just made.
Yeah.
Finally, I would like to expand the targeted specialty assessments to include the rheumatological diseases, because not only on your slide, it shows a high correlation or risk factor or risk ratio with fibromyalgia, but also other pain syndromes,
Yes.
such as irritable bowel disease. And I will be glad to share with you that there is no scientific study really investigating the relationship between distant childhood trauma and irritable bowel disease that I know of. So all these factors are very important in adult medicine, and they're largely overlooked, period, exclamation point. Thank you.
Yes. Dr. Gordon, that's a great point. I absolutely agree with you. We should expand, and I will take that as some important feedback, particularly on the rheumatological diseases. I think that's a great insight. So thank you for that. I wholeheartedly believe that there is a direct link between fibromyalgia and IBS, which, can often occur in fibromyalgia as part of the syndrome, that there would be a strong correlation between ACEs as well. So
Now,
excellent point.
When I
That
was
inflammatory cascade is clearly triggered.
when I was studying this relationship, I came across a very interesting study which assessed the nurses who had been involved in the National Nurses Health Survey, some, I believe, 200,000 nurses. They weren't using ACEs as their criteria, but those nurses who had been sexually abused had, I believe, 3 times the incidence of laparoscopy proven endometriosis
Mm,
than nurses who hadn't been abused.
wow.
So that transcends the shamefully disturbing concept that pelvic pain is due to psychology, and really shows the power of the endocrine system to create harm once abuse has happened.
Yeah, absolutely. Absolutely. Any other thoughts or comments? Thank you, Dr. Gordon. Those were great.
Since we're sitting here, I'll make another comment. Psychiatry is all screwed up. While the PHQ-9 has been validated for the DSM diagnosis of depression, the DSM diagnosis of depression has never taken into consideration the fact that some people who are depressed have child abuse trauma and some people don't, and they are likely to be 2 separate, different diseases. And psychiatry has refused to recognize that, and therefore all of the studies based on DSM diagnoses have untold complicating factors which may degrade their conclusions. And in fact, the NIH refuses to support any studies based on DSM diagnostic criteria. So the psychiatrist in front of you may not be as sophisticated or as concerned about this as you may want him to be.
Yeah, that's a great point. I noticed that Molly has put the NCATS webinar, also the link to that in the chat box. So for those of you that are interested in taking a look at that and getting a free CME, you're welcome to do that. And then you can follow our additional webinars in the future. After you sign up for this one, you'll be notified of our upcoming webinars related to asthma and toxic stress. We have just a few minutes left and another, Molly has also put our survey in the chat box. We have been very graciously awarded a grant from ACEs Aware to put on these webinars, and this feedback is compiled and goes to them. So we truly do appreciate the time, just a few minutes that it'll take you to fill out the survey, so we can be good stewards of our grant money and continue our relationship with ACEs Aware and the state.
Chris, I'll ask a question since I don't see any others in the chat. You know, somebody brought this up at another presentation that we were at, but sometimes, you know, we encourage screening for children, and we encourage screening for adults, right? So in some cases, the parent's going to be screened, they're going to be screened by 2 different doctors or 2 different places. How do people get around that? Or is there a way to know if a child's been screened from a parent or if a parent's been screened from a pediatrician? I don't know if you feel like you have insight into that, but I know that was something that somebody brought up.
Sure. So I think it's important, certainly as you, as a provider who's going over an ACE-Q or a PEARLS tool, that you ask, have you ever seen this form before? It can give you an opportunity to talk a little bit about why it's important, or why, particularly in California, it may be a new thing that providers are engaging in, hopefully, across the state. And so a parent may have gotten that in their pediatrician's office, and now they're coming to their own adult provider and they're getting the tool. And so it's a great way to reinforce the importance and that mind-body connection between toxic stress and the physical manifestations. And to say, you know, if your pediatrician hasn't asked you about this, certainly feel free to ask them if you feel comfortable offering that advice. And if a parent says, you know, I was screened at my pediatric provider's office in conjunction with my child, you might just ask them if they feel comfortable filling it out again for themselves. And if they don't, if they would feel comfortable sharing their score. And then just let them know that next year that, you know, with their annual, it'd be really important. You'd like to do that with them so that they're maybe more open. It won't hurt you to assess an individual twice. We just, there's little value in it if you're the same provider getting the additional information. So it just doesn't, it isn't cost effective to screen more than annually within your own setting. But that's a great question, Molly. I hope that provided some clarity. In a lot of OB settings, particularly the high risk OB settings, moms are asked what ACEs they've experienced in the past year as a way to screen the unborn child, as opposed to in their lifetime. So that can also be a unique way to look at the tool. And there's a great deal of information about maternal fetal depression. And so providing a mom, particularly who's had 4 or more ACEs, some additional training and information around maternal bonding, particularly if she has some comorbid depression, would be really important, and making sure that you talk about those high-risk behaviors in pregnancy as well. So that can hold a lot of value. We have partnered with an organization that did a shared medical appointment for their high-risk OB moms with a psychologist and the obstetrician and MFM prior to delivery. And then after delivery, they also brought in a pediatrician. So mom and baby were assessed in the same visit. And they've had a lot of wonderful success with that in the extremely high risk OB population. All right. Well, I think that we're going to give you 5 minutes back of your very important time. We all appreciate you participating so much today. And if you have further questions, please don't hesitate to email me or Molly. My email was at the bottom of the slide presentation. And we thank you again for filling out the evaluation in advance. We wish you the very best of the week and a happy 4th of July weekend to you all.